for a kidney transplant, and one of my main jobs while you're here is to teach you about some of the details of the transplant operation. We will also be determining whether there are any health issues that can be corrected before surgery that may make the operation and recovery more successful. So I'm just going to move to the board here for a second. The details of the operation were worked out in the 1950s and 1960s, and since then the operation has been standardized. The operation hasn't changed very much in the last 30 or 40 years. When we do the operation, we're only putting a kidney in. We're not taking your own kidneys out. So when we're finished the operation, if you have started with 2 kidneys, you'll have your 2 natural kidneys, plus the kidney that we insert during the transplant operation. We'll be placing the new kidney low down in the abdomen through an incision that some people say is shaped like a hockey stick, or perhaps half of a C. We can operate on the right side or the left side, and that decision will be made by your surgeon at the time of the operation. The new kidney goes low down and in the front. We don't see your own kidneys at the time of this operation, except rarely when a planned kidney removal, which is called a nephrectomy, is thought to be necessary, and that decision is made long before the operation. If that's going to be necessary, we'll inform you of that when you're here in Iowa City. The new kidney is attached to the blood vessels in your pelvis. It's done that way because the vessels in your pelvis are much more accessible and easy to reach than the kidney's own blood supply, which is high up and in the abdomen. There is an arterial connection for blood flow in, and a venous connection also for blood flow out. The last connection that we make during the operation is called the ureter to bladder connection. The ureter is a natural tube that comes with the kidney, and it's connected to the top of your bladder. The whole operation takes us between 3 and 5 hours. When we're done with surgery, you'll be taken to the recovery room or to the intensive care unit. In the intensive care unit, you'll recover for the next several days until you're stable and doing well, and then you'll be transferred to the regular floor. When you wake up from surgery, you'll notice that you're connected by several tubes and catheters. You'll have intravenous catheters for the administration of fluids and medications. You'll also have a urinary catheter inserted into your bladder for the drainage and recording of your urine output, which helps us to determine how well the kidney is working. Sometimes we also leave a small tube in the side that comes out near the incision. The end of the tube resides near the kidney and can suck fluid that might otherwise accumulate around the kidney. We don't always leave one of these drains, but sometimes we do. The urine tube and the drain, if we leave one, generally come out before people leave the hospital. Sometimes we need to leave them in a little bit longer, but that's not very frequent. Another tube that's just on the inside of the belly is called a stent. You can't see the stent from the outside. The purpose of the stent is to help the ureter to heal. The stent runs from the kidney through the transplant ureter and ends in the bladder. It's a little plastic tube. It's narrow, like a piece of spaghetti. The stent is removed about 3 weeks after the transplant operation through a brief procedure performed by the urologist. They take a scope, insert it in the bladder, take a hold of the stent, and remove it. That procedure takes about 10 or 15 minutes and won't bother you very much. Therefore, by the time that you're ready to leave Iowa City, the urine catheter, the drain, and the stent will all be removed. When we're confident that you and your new kidney are recovering well, you'll be released from the intensive care unit and released to the floor where you'll finish your hospitalization. Most people are here in the ICU for about 3 to 5 days and spend another week to 2 weeks on the regular floor before going to the hotel. So the entire time in Iowa City is usually about a month. Some of the main things that we're doing while you're recovering in the hotel are adjusting your blood pressure and diabetes medicines, adjusting your anti-rejection medicines, and monitoring the function of the transplant kidney. We continue to educate you about your new medications. The medicines that we use to prevent rejection are called immunosuppressants. While you'll be getting plenty of information about these medicines from the coordinators and pharmacy teams, I do want to take a minute to warn you about some of the side effects that are common and which you are likely to encounter during your early recovery. It's common for our transplant medicines to cause worsening of your diabetes and high blood pressure, or cause these problems if you didn't have them before. The good news is that for the majority of patients, these problems gradually improve. as we reduce the doses of the anti-rejection medicines. This happens naturally as we get further out from the transplant. Diarrhea, headaches, bad dreams, and tremors are also some of the side effects that you may encounter. It's important to remember to take your immunosuppression medications and know that you'll need these medicines for the rest of your life. Changes in the doses of the anti-rejection medicines should only be made by us, and you should call us anytime a new medicine is added or an old one is taken away by one of your other providers, as this may affect the blood levels of your anti-rejection medicines. The antibiotics that we give you after the transplant cover many of the common types of infection to which you may be prone. Rejection does not happen frequently, maybe in the 5 to 10% range early after transplant, and we've gotten increasingly successful at detecting and treating it to the point that losing a transplant early on is very uncommon. Technical problems, that is, problems related to the surgery itself, are not common, but still may be serious, and therefore I want to review some of the things that can go wrong with the surgery. There can be problems with the blood flow in and out of the kidney. These problems occur less than 5% of the time, but may threaten the success of the transplant. A reoperation may be necessary to fix a blood vessel problem. A narrowing of the ureter, which is the natural urine tube that I was describing before, or a leak from the ureter hookup to the bladder also may need to be fixed. But fortunately, these problems are also rare, occurring less than 3% of the time. Wound infections at the incision sometimes also occur and may require us to open the incision and give you antibiotics to treat the infection. Finally, I want to spend a few minutes discussing the waiting list and ways that you may be able to shorten your waiting time. If you have a willing living kidney donor, this can be a significant benefit. A living donor transplant is when one live person donates a kidney to another. Donors are often friends or relatives or people from your community, like fellow church members, or sometimes even people that you don't know well that just want to do a good deed. With a live donor transplant, you may get a kidney that lasts longer, has less rejection, and significantly reduces your waiting time. From the time that you are approved for transplant until a live donor transplant can be organized and scheduled is often 2 to 3 months. Evaluating the potential live donor is a careful and deliberate process where we do our best to ensure the safety and best interests of the donor. If you know of any potential live donors, please let us know so that we can give you more information about how the live donor process works. Unfortunately, the majority of our patients do not have a live donor and wind up waiting on the transplant waiting list. Wait times are currently between about 3 to 4 years. During that time, your health may change, and we may want to see you back here to update your transplant evaluation. In order to receive a kidney faster, UNOS, the national regulatory body for transplant, has implemented a program for patients who are willing to accept lower quality kidneys. By being willing to take a lower quality kidney, the waiting period is reduced. We call these lower quality kidneys extended criteria donor kidneys and abbreviate that as ECD kidneys. ECD kidneys tend to come from older donors, donors over the age of 60 or donors over the age of 50 with some medical problems that may affect kidney function. On average, an ECD kidney might function for 5 to 7 years.
Don't want that.
Compares with
Do
about
not
10
want
years
that.
in the average standard
I
criteria
do not
donor.
want that.
We have noticed that the waiting time for our ECD patients may be cut by as much as half of the usual time.
No ECD
The
kidney
reason that
for
taking
me.
an ECD kidney is beneficial is because getting off dialysis is such a large benefit to your health. So much so that taking even a lower quality kidney results in a longer lifespan than if someone tries to wait the extra time for a standard kidney. In summary, the ECD kidney program allows patients the chance to get off dialysis faster, which for many translates into a longer life. There are a couple things about the ECD program that are often confusing that I want to take a minute to try to clear up. First, if you should decide to go on the ECD list, it is not at the expense of being on the standard list. When you're accepted to the list, you will go on the standard criteria list. If you consent for the ECD list, you will have extra kidneys available to you, but it's not one or the other. Therefore, if you wait long enough, your name will eventually be called for a standard kidney. The other thing I want to point out is that very few of our kidneys are from truly perfect donors. The majority are from the middle-aged donors, and therefore may not be vastly different from any of the ECD kidneys that we accept. Your surgeon and transplant team is careful to select kidneys that we feel will work. We are not obligated to take every ECD kidney that is offered to us.
Hello.
ECD kidneys are not for everyone. Patients over 50, especially diabetics, tend to derive the most benefit from reducing their waiting time by being willing to take an ECD kidney. If you're someone who we think will benefit from an ECD kidney, we will inform you during the evaluation process. We can answer your questions and explain any details of the ECD process that may not be clear, as we realize that the decision about whether or not to sign up for ECD can be nuanced and confusing. I want to again take this opportunity to welcome you to Iowa City. I or one of my surgical colleagues will be meeting you personally during your visit, and we're looking forward to answering your questions about the transplant process.